Hello, everybody. Welcome back to the podcast. We are joined by Melissa House and Megan Legoski. Megan, Melissa, thank you so much for joining us today.
Thank you for having us.
So you are part of a focus group called PMAD. Can you tell us a little bit about what PMAD is?
Yes, so PMAD stands for Perinatal Mood and Anxiety Disorders, which is a growing interest, I would say, in the neonatology kind of field, as well as generally over kind of globally with pediatrics. So we are a newer focus group within CHNC. We developed 2 years ago after both Megan and I have shared interests with severe BPD as well as in better support of our families in transitions in care and also support of parents who are suffering from mental health and the stress of the NICU. And we heard a wonderful presentation from the group in DC 2 years ago and reached out to Lamia to just find out how she started. And with that, we enrolled more people from other centers that were interested in this growing field. And now we're trying to collaborate within CHNC to see if we can improve the mental health care of parents in our NICUs.
Because it is really a part of family-centered care, we feel. And it affects infant health, child health. It affects us and our ability to interact with families. And so it should be a priority.
Yeah, I mean, even if you look outside of the NICU population, we know that parent mental health problems / disorders, affect outcomes, health, and developmental outcomes, and it's just magnified in our NICU population. So I'm super excited. I want to hear what you guys have been working on.
Well, our big thing that we've been working on is sending out a survey to our level 4 referral centers on both what kind of mental health support they have available in their hospitals and also if they're actually using validated screens to detect depression and mood disorders and anxiety in the parents. We know that these surveys have been sent out to other centers before, but we thought that there might be some unique challenges in our referral centers because some of the other centers that are level 2 or level 3 are enfolded within a perinatal center, and so the level of support will be different, we would anticipate.
Well, I was going to say, so many of your centers are referral centers, right? So
Right.
babies also have to maybe be far from home,
They
so
are.
it adds a whole nother layer of complexity.
Right.
And I was going to ask, when we screen families, I wouldn't be surprised if everybody screened positive. Or how can you remain at your baseline when your baby is in the ICU? There's no way to not be affected by that. So how do we determine what's within normal, meaning there's an appropriate level of anxiety that is not impacting negatively the family versus something that needs help? Yeah.
No, I think that's a really great point, and I think that as clinicians, and even our social workers struggle with that, where you can roll out a screen, but unless you have the ability to have better mental health services ingrained in your NICU to help kind of tease some of those things out of, is this normal situational anxiety and depression? Is this something more? And so I think that our group is great in that it's multidisciplinary. We have psychologists, social workers, physicians, a nurse who has an interest. And so we're growing and trying to navigate that. And one of our future projects that we really hope to work on is, do we need a better screening tool? Is a general postpartum depression scale really appropriate for our NICU parents, as well as anxiety and also trauma and screening for trauma in the NICU.
And how the state of mind of families is very much evolving. The level of anxiety at the beginning of the admission versus 2 months into it is a whole different ballgame.
And the timing of screening from what limited data we have matters. And so there's a PACE study that came out that said that over 50% of families, if you screen them within the first 2 weeks of admission, have psychological distress. And so a lot of centers, although to be honest, there's not a ton, and it's definitely not even half of centers that actually have standardized formal screening. They wait until after 2 weeks often. Or sometimes they'll do it on the time of admission, but you have to be careful and then think about repeat screening. which is hard because we have limited staff to be able to do that.
Yeah.
Absolutely. Well, that's what I wanted to ask. I anticipate that you will find what has been shown in the literature, that there's a lot of variability that trends towards not screening and not having mental health professionals integrated in the unit. So what would be the next steps? What would be the vision, you think, for the group about how we can tackle that problem?
We are working on, because a lot of, especially level 4 units or referral centers aren't associated with an adult facility. And so providing adult health services within a children's system is really challenging. And then to tackle on mental health, which doesn't always have the best support and coverage by insurance, and concerns from legal about how to tackle this and support families. And so many centers who have done this successfully, we're trying to learn from them within our group. And then our goal would be to kind of create a toolkit of these are things that have worked in the past for other hospitals, how they've presented to leadership of what the value is. And not only this is the improvement we've seen in our families and family satisfaction, and hopefully influencing neurodevelopmental outcomes, which is, everyone's goal, but also these are the things that mental health services can do to help our staff, to help bedside providers, to help them interact with the families, but also manage their own grief and trauma in certain situations. And many psychologists have commented that they consider themselves like revenue extenders and help support staff longevity and less turnover by just making a more cohesive unit that supports the families, obviously, is our goal, but also everyone, because what we do every day is really challenging. And so that's our hope, would be how can we create a toolkit for other centers to be able to model of this is the value, and this is how other hospitals have approached it, and this is how we can mimic that.
And tacking on to that, this is not trying to get ahead. This is actually trying to meet what has already been defined as the standard of care, and it's actually
Daphne says that. Daphne will come out and be like, this is not even improvement. This is standard of care.
Right. So within the last 6 to 12 months, the AAP just came out and said that level 2 plus NICUs need to be doing or standardizing screens for mood disorders in families. And also, the presence of NICU dedicated psychology support is actually one of the U.S. News and World Report measures. Yeah, metrics.
Yeah, I think, unfortunately, I think that's what's going to change the tides, is when it becomes a part of the metric system. And I'm hopeful that groups like yours that really have a lot of institutions will help set the goalposts and set the standards, so that way we will all have to fall in line.
And when looking at outcomes, so we can help parents for sure, but what are the impacts you'll see then on the baby and their hospitalization?
Right.
Any data on that?
Not yet.
But
we do know that parents with mental health disorders or mood and anxiety disorders actually do have a tendency, maybe not even within the hospitalization, but beyond that, miss appointments for their children, and so it can actually impact their long-term
I was
health.
going to say variables. To me, that sounds like easy outcomes where you would see an improvement would be missed follow-up appointments, readmissions, or revisits to the ER, and then delayed discharge, where how the parents that's not ready to go home. I think yes, if you've managed symptoms of anxiety, depression on the front end, then I'm sure they'll be more likely to be discharged on time.
That's been
length of
described.
stay.
That impaired bonding, impaired proficiency in the parenting skills, really impacted the NICU admission. So, it's very exciting work. We're really looking forward to seeing what you guys come up with. Before you go, we're asking everybody if you can share something that you've learned at the conference that you're going to take back to your home institution. It doesn't have to be from
Right.
this topic necessarily, but
Mine has obviously gone blank right now.
That's all right.
sometimes it takes time to process all the new information, you know?
Well, we were privileged to also attend
Yes.
the BPD colloquium the first day and a half prior to the annual
Yeah.
symposium starting, which is just really great for us, very like-minded people.
Right.
And Megan and Miller Shivers, who's the psychologist at Lurie, are working on a really wonderful project at looking at infant attachment and improvements in the NICU and how that might be associated with delirium, and can poor attachment actually be a sign, can it actually be poor attachment instead of delirium? Some of those symptoms might actually cross, which has inspired me a lot in thinking about how to implement that in our unit with our patients who have really long lengths of stay. So that was really fascinating to me.
Yeah, and I think that might actually help us with doing so many other things that can benefit patients from a neurodevelopmental standpoint, like avoiding prolonged neurosedative use. If we can have these parents, not necessarily, I mean, they can't really be there all the time. A lot of them can't. There's a lot of limitations to their ability to be in the hospital. But having that meaningful time and understanding how to parent their infant and how that evolves as they get older, I think and letting them take an active role will go a long way in improving their outcomes.
Love it. Well, thank you both for joining us today. We really appreciate it.
Thanks for having us.
Keep up the good work.
Thank you.